Well, welcome everyone. Thank you for joining us for today's public forum, Stronger Than Sticks and Stones, Promoting Women's Bone Health Through Preventive Care. I'm Katie Schubert. I'm President and CEO of the Society for Women's Health Research, and SWHR is the thought leader in promoting research on biological sex differences in disease and improving women's health through science, policy, and education. Earlier this year, SWHR's Bone Health Working Group convened for a roundtable meeting to discuss scientific and policy issues related to the impact of bone health and disease on women throughout their lives. Members of this interdisciplinary working group include researchers and healthcare providers with expertise in women's health and bone health, from pediatrics to geriatrics. We also engage patients, patient advocates, and healthcare policy leaders. Today's public forum will share highlights from the discussions that took place during the closed meeting, building awareness around key research gaps and unmet needs in clinical care, education, and policy, with the goal of improving care for women's bone health across the lifespan. We are pleased to have three distinguished panelists joining us today. Dr. Keith J. Loud, Chair of Pediatrics and Physician-in-Chief at the Geisel School of Medicine and Children's Hospital at Dartmouth University, Dr. Deborah Mutsuko-Kato, Professor of Medicine at Stanford University School of Medicine and GRECC Veterans Administration Health System, and Dr. Catherine Sharp, Associate Clinical Professor at the University of Maryland School of Public Health. I'd like to thank the sponsors of today's event, Amgen and UCB. SWHR maintains editorial control and independence over program development, content, and work products. And as always, we are live tweeting today's event, and we invite you to join us using the hashtag SWHR Talks Bone Health on social media. And with all of that, I would like to introduce SWHR's Chief Science Officer, Dr. Irene Anyinye, who is moderating today's forum.
Thank you, Katie, and welcome everyone. An estimated 54 million Americans have low bone mass, resulting in an increased risk for weakened and brittle bones and bone diseases such as osteoporosis. Fracture risk is higher in women compared to men, partly due to women having smaller and thinner bones from the influence of the hormone estrogen. Approximately half of women over the age of 50 will break a bone because of osteoporosis, which can be life-threatening and result in the need for long-term nursing care. Today's presentations will share more about bone health, its effect on women's health, and some strategies that SWHR's Bone Health Working Group recommends for preventive bone health care and disease management to reduce the clinical and public health burden for women and broader society. I'll now introduce Dr. Keith Loud, who will talk to us about biological sex differences in bone health throughout the lifespan and current guidelines to promote peak bone mass and preventive care. Thanks for joining us, Dr. Loud.
There we go, unmuted. Thank you, it's good to be here. It's interesting, as a pediatrician, you may wonder why I'm here in an osteoporosis forum, but we speak about osteoporosis being a geriatric disease with pediatric roots. I have no conflicting disclosures to present. I'm going to talk briefly and quickly to set the table on biological gender differences, bone health from adolescence into adulthood, and peak bone mass and preventative care as important concepts throughout the lifespan. So as Dr. Anyinye mentioned, osteoporosis is a bone disease related to bone mass. This is a representation of a DEXA scan that we use in clinical practice to diagnose and manage osteoporosis. And the impacts are lifelong or can certainly be felt in older adulthood. And when we think about bone mass as a key contributor to osteoporosis, almost unfortunately, a significant number of the determinants of bone mass are intrinsic, unchangeable, or unmodifiable, those being gender, family history, and genetics. And in some ways, those are three ways to say the same thing. This is a schema of the impacts on bone mass. And in bold are those unchangeable factors, much like our height or our hair color, that we can't necessarily improve upon. Then there are the extrinsic or modifiable factors that can allow us to potentially improve our bone mass. And some of those I put in italics actually are going to have a genetic component as well, and we may not be able to modify quite as much. But The real story is that peak bone mass, PBM, is one of the most significant predictors of postmenopausal osteoporosis. And that peak bone mass is achieved by age 25, if not sooner. A quarter, 26% of total adult bone mineral, bone mass, is acquired during the 2 years before and after peak height velocity during adolescence, during the pubertal growth spurt. And this curve is really sort of representative over time, bone mass and age in years. And on the right side of the screen here, you see either low bone mass, sometimes called osteopenia, and osteoporosis. Ultimately, if any of us, including men, lived long enough, our bone mass could reach into the low bone mass or the osteoporotic range. But at the beginning of life, in those first 2 decades, the bone mass increases rapidly with growth. And the higher we can get this peak, the longer we can stay out of those danger zones. And you can see, we'll talk a little bit about how the peak bone mass differs between males and females. And menopause causes an accelerated decrease in the bone mass. So that's why this is really a more important issue for women, for sure. Although men, certainly, like myself, again, if we live long enough, that gradual decline will continue after, well, where I am now age-wise. And what we're trying to avoid also is this dotted line in the bottom, where if you don't take those intrinsic or those modifiable factors, those lifestyle factors are not optimized in the early ages, then you will not achieve potentially your highest peak bone mass and decrease the opportunity to fall into these danger zones postmenopausally. This is a graph that shows how boys will have their growth spurts later in age, generally speaking. Is peak over here, on the right, versus girls on the left. And they don't achieve as much of a peak acceleration in accumulation of calcium within the bone bank. That bone mineral, that bone mass is really driven by the calcium put into the bone bank. And so boys get it later, but they get more of it. There's some interesting lag periods between height and peak bone mass, where actually kids can have a relative weak bone mass because their bones are bigger than they've been mineralized. And this is just a cascade showing the various hormones that are at play around the beginning of menses for adolescent females, and the Tanner stage development and height velocity. The bone mineral, that peak of putting calcium in the bones, lags when they have their growth spurt, as we described, that height velocity, and shows the importance of a variety of hormones, perhaps none more so than estrogen and testosterone, even for girls, but estrogen really being a driver of bone mass. So the determinants of bone mass, as we say, again, I talked about the intrinsic, and when we think about the extrinsic or perhaps modifiable lifestyle factors, including diet, body habitus or size, body mass index, hormonal milieu, illnesses and treatments, lifestyle choices and exercises, as factors that could maximize bone mass. The National Osteoporosis Foundation, in a position statement, identified lifestyle factors and noted the grade of evidence associated with each of them. And ultimately, only calcium, vitamin D, dairy, and then physical activity and exercise fell out as having high quality evidence behind them in terms of the impact on bone mass. So I highlight in bold the diet and exercise as really the two areas, the exercise and the diet, that we can modify to improve that peak bone mass. And it comes down to calcium. Optimal calcium intake is between 1,300 to 1,800 milligrams of elemental calcium a day. There are increased requirements during periods of rapid growth, but the longitudinal studies really show that supplemental intake can improve body mass index, bone mineral density, BMD, not body mass index, bone mineral density in children and adults in synergy with physical activity. One without the other doesn't work. You need to actually have a stimulus to put calcium into the bones with physical activity. Of course, vitamin D is the other major important micronutrient that is critical for normal calcium absorption from the diet. There's a whole host of risk factors for deficiency, including inadequate diet, inadequate sunlight, sunscreen use, which is important, the adolescent lifestyle, which incorporates perhaps an inadequate diet, some anticonvulsants and other treatments, as well as obesity, and living in high latitudes, as I do. So many of us simply just cannot get enough conversion of vitamin D from the sun where we live. So This has been a question I've asked with my pediatric colleagues over the years. Is 600 units supplemental vitamin D the answer, or higher? I think it's at least 600. This is the Institute of Medicine, or now the National Academy of Medicine, recommendations both for calcium and vitamin D, and again, at least 1,300 or so on the calcium side, and that 400 to 600, probably more than 600 for everybody. I have my patients, boys and girls, taking 600 units of vitamin D if they can for a supplemental vitamin every day. So those are the micronutrients. When it comes to macronutrients and the like, overweight in bone within a healthy range, bone mineral density is nicely associated with body mass index. There's some association between overweight and increased fracture, which may be questioned about the fat cells on bones, greater momentum to the falls, or decreased fitness levels. But generally speaking, in a healthy range, more fitness improves that bone mass. But there is this element on the lower end of the spectrum. People worry about overexercise in the female athlete triad, is what it's known as. Sometimes we call it the athletic energy deficit spectrum. And the deleterious, the negative end of the spectrum here in the red triangle is what's often known about, if it's known about, low energy availability with or without an eating disorder, leading to amenorrhea, lack of periods in adolescence and young adulthood related to, which causes low estrogen, and that can lead to low bone mass. However, there's a positive end of this spectrum, and those girls and young women who are participating in sports, maintaining their periods by giving themselves adequate energy availability, appropriate fueling for their exercise, achieve optimal bone health. So we want to emphasize and promote the green end of the spectrum and not over worry about the red end of the spectrum, because there's a real window of opportunity that exercise is perhaps the most modifiable and effective extrinsic or lifestyle choice that we can do to augment bone mass in early puberty, really early, ages 10 to 12 in girls or 12 to 14 in boys. It really needs to be a lifelong commitment, and it really needs to be weight or load bearing activities for developing bone, that's jumping, running, or hopping. The activity needs to increase muscle strength. I know Dr. Akata will mention the unit, the muscle bone unit, as an important component. The stimulus must be greater than usually encountered. It can't simply be walking regularly, and you lose it quickly. If you don't use it, you lose it. So in summary, I emphasize as not only a pediatrician, but a sports pediatrician, bone stimulating exercise balanced by nutrition to maintain a healthy weight with those dairy products is among the best ways to achieve adequate calcium intake and optimal vitamin D levels. Don't forget smoking alcohol. Those are bad for kids and bad for bone in general. And I look forward to the rest of the presentations.
Thank you. Thank you very, very much, Keith. Please note that those who are tuned in live can submit questions at any time using the Q&A box at the bottom of your screen, and we'll try to address as many questions as we can during the panel discussion portion of this event. Next, we'll have Dr. Deborah Cotto discuss bone health and disease disparities in women, highlighting clinical guidelines and gaps that are important to address in order to improve care.
Thanks so much, Irene. So to begin with, I have no conflicts of interest to disclose with regards to this presentation. Next slide, please. So our population is growing older, and so is a likelihood that we will have osteoporosis. And in fact, women are at particular risk. And so I'm glad that the Society of Women's Health Research is focusing on bone health this year. And this is for a multitude of reasons, one of which Dr. Loud had mentioned. Women have lower peak bone mass than men in general. And after menopause, accelerated bone loss does occur. And when women fall, unfortunately, they tend to suffer more injurious falls than men, as well as we tend to live longer than men. It is estimated that osteoporosis affects about 10 million Americans, of which 80% are women. Next slide, please. So I've been charged with thinking about promoting bone health through preventive care. And I see that the best way to do this is really to empower women. So some of the major modifiable risk factors to promote optimal bone health through a lifespan are things such as bone and falls and diet, but I'm going to spend the next 9 minutes or so really focusing on muscle, and unfortunately cannot speak about diet too much, but we'll hint on it at the end. Next slide, please. So when patients come to see me, it's really about preventing the fracture, right? That's why we care about osteoporosis, because if we had terrible bone density and never fell and had a fracture, we wouldn't even know we had it. So if you look at this diagram, on the left-hand side, there is low muscle strength, right? And low muscle strength, you'll see a bidirectional arrow with low bone density. And in fact, science is continually showing us that there are multiple ways in which low muscle strength and low bone density are highly correlated. In addition, low muscle strength is a known risk factor for falling. And falling really in older adults is the main reason why people fracture. Like 95% of fractures occur because someone falls down. You will see a smaller arrow going from low bone density to hip fracture, because certainly we know DEXA, low bone density, is a strong risk factor secondary, to age for someone having a fracture in the future. And then finally, the smallest arrow is going from the hip fracture to the fall, because in very rare cases, it is possible that the bone may first snap leading to the fall. So just thinking about this diagram and what is leading to what is a good place to start. Next slide, please. So one could ask the question then, if looking at low muscle, both leading to low bone density and to falls, could it be the most important factor in contributing to fracture risk in older persons? When you look at large epidemiologic studies, in fact, most fractures do occur because of a fall, 83% in women and 83% in men and 87% in women. And of note, when one considers fall risk factors, it's muscle weakness and not low bone density that is listed. In fact, if you look at some of these observational studies, the proportion of fractures that are attributable to the bone density T-score less than -2.5, it's really modest, ranging from less than 10 to about 44%. Next slide, please. In fact, though, if you look at the scientific literature, more epidemiological studies highlight low bone density rather than muscle weakness as the important fracture risk factor. There are multiple large cohort studies from across the world that demonstrate a strong association between DEXA, low bone density, and increased fracture risks. There are fewer studies that have shown an association between muscle strength and/or muscle performance and fracture risk, and even fewer that have compared low bone density versus sarcopenia, which I'll define in the next slide, and fracture risk. Next slide. Why has there been more of a focus on bone rather than muscle when both are important for skeletal health? Maybe consider that for a second as we move to the next slide. So sarcopenia, defined as low muscle mass and strength, are just simply harder to characterize. So perhaps that's the major reason we don't have more studies on it. But if you look at these two examples of a cross-section from a CT of thigh muscle, you can see young, healthy thigh muscle on the left and sarcopenic thigh muscle on the right. And you can imagine that if either of these two individuals owning these thigh muscles were to fall down, that the one on the right would be more likely to have a fracture. Next slide, please. So sarcopenia, now since about 2016, is actually a clinical diagnosis with an ICD-10 code, and it is defined as low muscle mass and low muscle strength or performance. And it is considered to be the most important cause of frailty in older persons. There is a clinical definition used that one needs to have a walking speed of less than 0.8 meters per second and grip strength less than 20 kilograms in women or 35.5 kilograms in men. When in the past, the DEXA body composition and lean mass has been used to try and get at whether sarcopenia defined in that way is associated with fractures, and largely has not been able to show that association. But there is a new measure of D3 creatine muscle mass and strength that has been shown in the past 5 to 10 years to be associated with lower gait speed, prevalent mobility limitations. It's been associated with an increased likelihood of developing serious injuries, falls, incident mobility limitations, and finally fractures, published this past summer. So it may be that when people tried to get at sarcopenia with different definitions, they were just not successful in really getting at that low muscle mass and low muscle strength or performance. Next slide, please. So don't want to ignore bone, however. So for the individual who has a low bone density or maybe not have a low bone density by DEXA, should you be worried about fracture? I think that one should pay attention to some other important signs and symptoms to consider when assessing your own fracture risk in the future. One is having a family history of osteoporosis, in particular hip fracture in a mom or dad, aunt or uncle, previous personal fracture history. Data from Canada suggests that no matter what kind of trauma fracture you had, including from motor vehicle accidents, in the ensuing 20 years, those people who had those types of fractures were also more likely to have a future fracture. And finally, it's very important to consider balance, coordination, and a history of falls. So if you self-define yourself as a klutz, you might think about your risk for future fractures as you get older. Next slide, please. So, can't say much more as a geriatrician about preventing the fall, because preventing the fall will help to prevent the break for sure. And we know that about 30% of community dwelling older adults who are over the age of 65 report falling every year. And if you're lucky enough to live up past the age of 80, about half of those individuals will fall in a given year. And one of those, in 5 of those falls are likely to be injurious, resulting in broken bones and head injuries. Next slide, please. But I'd like to turn back to muscle for a moment, because it's really the muscle quality and strength that is a crucial factor in determining who is going to heal the best following a fracture. It really, how you do depends upon your pre-morbid muscle strength, meaning how were you doing prior to the fracture. So if you were sarcopenic, the likelihood of regaining independence after a hip fracture is definitely questionable. Of course, it's important that bone density and geometry, the degree of mineralization, microarchitecture, and bone turnover are important for healing. But I would argue that without sufficient muscle function, even with healed bone, patients will never be able to regain their previous function unless their muscle is adequate. Next slide, please. Fortunately, over the past 25 or 6 years, 30 years even, we do have multiple medications available to help us with our bone health. So very important, if you do have DEXA low BMD and have those fractures, treatment is definitely on the horizon, and you have multiple examples of FDA-approved medications, mostly the bisphosphonates that you will see, alendronate, risedronate, and zoledronate acid have been shown in multiple randomized controlled trials to prevent all types of fractures, as well as denosumab and romosozumab, the most recently FDA-approved medication in 2019. Next slide, please. But with all those medications already FDA approved, I'd like to point out that bisphosphonates are still the #1 for osteoporosis treatment. Not forever, but they are excellent, and all medications will eventually end up with patients being on them if they're being appropriately treated for osteoporosis. That was FDA approved in 1995, and sometimes it's hard to remember to take a drug once a week, so the compliance and some of the side effects, the GI side effects, make it less effective. However, zoledronic acid, the once yearly dosing IV for 3 to 5 years, is very effective for those who can't take it because of stomach issues. They're interestingly not publicized a lot, but multiple randomized controlled trials suggest that the people who actually got the drug of the bisphosphonate survived longer than the people who got the placebo effects. The other important thing is to consider is how long does it take to see an effect of a bisphosphonate if you're going to take one? And it's been shown about 12.4 months, as opposed to say 2.5 years for statin therapy to prevent a heart attack or stroke. Next slide, please. So in summary, physical activity does a lot to optimize both muscle and bone and is extremely important, but so does diet. So I just include these 3 images of very healthily aging older individuals who are very distinguished and clearly are physically active on a basis. In fact, Tao Porchon Lynch, the Guinness Book World holder for yoga teaching, had a wrist fracture as well as a hip fracture, and she was determined to get better. And as you can see, she's doing what I still can't do on her wrists that were previously broken. All of them, when you ask them about the diet, do say a lot about vegetables and fruit. So a well-balanced vegetable and fruit-based, non-processed food, minimally processed food diet is what I recommend as a geriatrician. And finally, the last slide, please, is just to be left up to let you know that there are physical activity guidelines for adults. And I think due to time limitations, I'm just going to let you read the slide, and this will be on recording so you can see what is recommended by exercise physiology and other types of experts for optimizing bone health and healthy aging in general. Thank you so much for your attention.
Thank you, Dr. Cotto. Now I'd like to introduce Dr. Kathy Sharp, who will share her personal journey living with osteoporosis and how it sparked her passion for advocacy in this space.
Hi, thanks everyone for attending. I'm very, very excited and honored to be a part of this webinar. My name is Kathy Sharp, and I'm a patient with perspective. A patient with perspective and also living with osteopenia. So I'll tell you my journey from osteoporosis to osteopenia, which is always going in a positive direction. So I'll just start with some background material just about myself, just to kind of give you some context. I was born in Washington, D.C., and then I think I was 1 or 2 years old, and we moved to Bethesda, Maryland. I lived about a mile from NIH. My dad worked for the FDA for 30 years, and my mother was a nurse, in a hospital in the nephrology unit, and got into, later in her career, got into advocacy on the behalf of nurse practitioners. So I come from a family that's pretty kind of more medical, clinical oriented, but there was a lot of public health focus. I have one sister. She's 1 year and 9 months older than me, and I didn't experience any adverse childhood experiences, which we call ACEs. So that's just a little bit, middle income, lived in Bethesda, Maryland, and lived in Maryland the majority of my life. So the beginning of my osteoporosis journey, I'd say probably began when I was going through puberty. So I didn't start menstruating until I was 15. My mom and my sister started menstruating when they were 11 and 12. So I was late, kind of, going with my family history, and that completely turned me off. The whole body changes and all that kind of stuff. And obviously there was a lot of other mental health issues going on when you're going through adolescence. But at that time, I felt the solution was to not eat. And you never really know what gets all that started, but usually it's self-esteem and stress and all that kind of stuff. But I didn't like my body changing, and so I started starving myself, and I lost 30 pounds. At the time, I weighed 115 when I started menstruating, and I'm 5'2", 5 feet and 2 inches tall. And so I lost 30 pounds in about 9 months. So it wasn't rapid, but I did get down to 85 pounds and did not look well at all. And I developed amenorrhea, which is absence of menstrual periods. So because I had only had one normal period, I never even really developed a normal cycle. So anyways, one morning I was walking to the bathroom, and my dad said, "Get on the scale." He saw me walk by because I'd walked past my parents' bedroom. And, because he could see that my legs, I was like in a t-shirt that I wore at night. And he said, get on the scale, and he saw the 85 and, you know, pretty much outed me, but I really had hit rock bottom at that point. I really was looking to be saved. I just needed help. So anyways, off to a million doctors. So first I started with my primary care, and then went to an endocrinologist, and then from an endocrinologist to a nutritionist. But at that time, I wasn't in a dangerous place where I needed to be hospitalized. I was someone who would eat. I just wanted to be very careful about what I ate. And I recognized that I had a problem and that I really was looking for help. But I just didn't know what that help looked like. So I was prescribed oral contraceptives to kind of regulate my period. And I did put on slow, steady weight. I got up to about 100 pounds within the next year. And that was satisfactory for my doctors. Of course, they would have liked it if I had gained more, but it was difficult for me to do that. So moving through the ups and downs of my journey with osteoporosis is I went to college, and next slide, please. Thank you. Yeah. I'm talking about the ups and downs of my journey. So I went to college, and I went to University of Maryland. So I was still within 20 minutes of home, and I was living in a dorm, and the food was not great. And the stress of being a freshman and having a roommate I didn't like. Most people gained freshman 15. I lost the freshman 10. And that was by Thanksgiving. My parents looked at me and said, okay, that's it. You need to get into therapy. So I found some group counseling, was bulimics and anorexics on campus. And then I got my own individual therapist, which I think I did better in. And I started that. And it was about 6 years of therapy. And it was challenging. It was challenging to kind of get at all of my problems. But anyway, so I held steady at 100 pounds, but it was never enough to menstruate. And so I think that was the main cause of my osteoporosis. So I get my undergraduate degree. I worked for 4 years. I hit this, quarter life crisis when I'm 25. So I go to get my master's degree. And at this time I knew I wanted to get a master's in public health. And so I applied to Emory University in Atlanta, and I went there to get my master's in public health, and I got my major in behavioral science and health education. And during that time, if you know Emory, there's a hospital on campus, and the CDC is right next door. They have a clinic on campus that is a training, hospital for doctors, because they have a medical program at Emory. But they are running, most hospitals are running clinical trials a lot of the time. Anyways, they would put up notices in my building, in the School of Public Health building, because they knew we were poor students and we were, relatively healthy, and they needed healthy subjects to participate. Anyway, so there was a test that was a urine biomarker to measure if you had high bone turnover. And so it was $50. You go, you urinate in a cup, and it was a done deal. So I got my results from that, and it said you have really, really high bone turnover. Follow up with your healthcare provider. Okay, so I'm in the last year of my master's program. I'm like, okay, I'll deal with that later. I wasn't really too concerned. But anyways, so I graduate from my program. I stay steady at about 100 pounds through my whole master's program. I graduate when I'm 27. I come back to Maryland. I go back to my primary care provider that I had seen, through the beginning of my whole osteoporosis journey. She's like, oh yeah, you need to get a DEXA scan. So I get the DEXA scan. I have the bones of pretty much a 98-year-old woman. And it was shocking, but I didn't really see the grand picture of it. So I did start seeing an endocrinologist. I was put on a series of bisphosphonate medications. Some of them worked, some of them didn't. Some I had side effects, some I didn't. A lot of trial and error. But what I did do is I really started to get active in advocacy. And so I did some work with the National Osteoporosis Foundation. They have a new name now, but and I did through them, I got connected with some people at NIH, and there was a consensus development conference. So I was a patient on that perspective panel, and I also testified in front of Congress about the importance of addressing osteoporosis and Medicare coverage for DEXA scans. I continued to fracture. I had really minor, I wouldn't call them minor fractures, but they were stress fractures in my feet, which again would limit my exercise. And so I would gain weight, but I wouldn't feel good about that weight. And so it was just kind of this whole series of ups and downs, and being a guinea pig. Next slide, please. And being a guinea pig in that all these medications that I was being prescribed weren't approved for premenopausal women. And so I'm not sure where the kind of the cost benefit analysis, because nobody knew if I was going to have children. Nobody knew what the long term, like, am I staying on these drugs forever? Are we fixing this? And then I'm going off of them. There was like no like long term discussion. And I just felt like I'm just going from, you know, like pill to pill. Some things are working, some aren't. I just kept getting DEXA scans every year, and bone turns over very slowly, you know, gets better very slowly. So it was just a long and very concerning journey in those, and I wouldn't even say it's the early days. I mean, now I'm probably, you know, 6 years into it. So next slide, please. I go to get a PhD after I worked for another 4 years in between my master's and my PhD. And I see a woman at Cleveland Clinic, and she says, you need to get off the bisphosphonates, you know, exactly for the reasons that I had mentioned. And I go back on oral contraceptives, which I didn't really want to be on. I continued to have stress fractures. And then in 2013, I got a DEXA scan. I had significant improvement in my DEXA. And I was like, wow, that was exactly 10 years after I went off the bisphosphonate. And bisphosphonates have a half-life of 10 years. So I think that had a kind of hope, a hopeful time in my journey, and that I thought, wow, things really are getting better. So anyway, so I've been continuing to work through my osteoporosis with my primary care provider. I never did menstruate normally. I'm now 53 and postmenopausal, so I'm constantly worried about that. I do have an excellent diet. I'm not fracturing, and I feel strong. My weight is stable. I feel like I'm in a lot more control over my condition. Next slide, please. And I've kind of come to the realization that I'm no longer willing to be a guinea pig. And so I do work with my doctors a lot closer, and I feel like I have a much not louder voice, but a more prominent voice in the discussion. Next slide, please. So I'm still being very involved. I'm involved with the American Bone Health organization right now. I'm on their board of directors. So I'm still interested in advocacy, as well as educating younger audiences. So while there's no doubt that anorexia led to an elevated risk or onset of osteoporosis in my situation, I'm not really 100% sure that I wasn't already destined to be osteopenic my entire life, simply because of my weight and my height and my small body. And no one ever talked to me about that. You know, they just said, you're incredibly abnormal. And so we need to fix this with medications. And that was disarming to me. Next slide, please. So just some barriers that I experienced. I didn't really experience traditional or common barriers that people have, like money, time, or insurance coverage, but I didn't have one primary care provider overseeing my entire journey. And that's because I was moving all over the place. But also the science is still relatively new, especially with osteoporosis prevention, osteoporosis medications. There is a lack of tailored prevention messaging, treatment after the fact. Prevention messaging and treatment is usually done after the fact. There's, of course, a stigma of eating disorders. So if you walk into a provider's office and they know that you either have an eating disorder or you had an eating disorder, subconscious, subconscious, conscious, people just have biases. And so you're kind of put into a box and treated one way when you may not really have issues anymore. And then there's fear. And so your fear of fracturing, your fear of taking medications, fear of exercising, fear of getting DEXAs and getting the results. There's just a lot of fear that can interfere with the patient-provider communication. Next slide, please. That again, like I said, I'm constantly advocating for change and would just like to impart some kind of like final messages before I wrap up. I was provided with scare tactics. You're gonna, you have the bones of a 98-year-old, you're going to fracture your wrist the next time you pick up a grocery bag. That was not successful with me. And I wanted to feel empowered and like motivated and that I had control over my condition. And I didn't feel that for about the first 14 years. And I think that had detrimental effects for me. I would like to see more patient-provider communication in the medical school curricula. I know I'm not the only person. I do believe that primary care providers can and do more. They do have a lot of skills, and I think a lot of medication can be prescribed and managed through them. And then lastly, I really think prevention. I'm in public health. Prevention is where the things, where the message should be coming from. Treatment is not how we should be approaching this after the fact. Next slide, please. Patients do dread being labeled. We really, once you get a condition, you get a diagnosis that goes with you for life, and it can become a mental health issue. So not only did I have the anorexia and coming out of that for 15 years, I also was diagnosed with this condition. These things are showing up in my medical chart, and people are forming biases about these things. The other thing is I'm not an old white woman with a dowager's hump, yet that still seems to be where the money is today in 2022. I personally would like to see more focus on tweens, young adults, BIPOC, men, LGBT, cancer survivors, people living with HIV, autoimmune and GI issues, who are on medications, who are young, where we can get to them early and get messages to them about the importance of diet and exercise and other things like that. So that's my story. I'm open for questions, and thank you very much for your time.
Thank you very much. And thank you everyone for sharing and setting the stage for the Q&A portion of this webinar. Again, we invite attendees to submit questions using the Q&A function at the bottom of your screen. We'll try to address as many individual questions and common themes as we can during the discussion. To open up the conversation, I would like to ask, Dr. Loud, you talked about, developing peak bone mass in adolescence, in early age. And then we also, but if you are older, what can women do to maximize their bone health as adults? So if they are 40, 50, or 60, and they're watching, what recourse do they have now?
Yeah, so I was pleased Dr. Cotto wasn't able to speak to it. Maybe she can now. There are guidelines and recommendations for adults in terms of physical activity, specifically for overall wellness and specifically bone health. And Deb, I mean, I saw tennis and some other things on there. So I'll if I might, I'll let Dr. Cotto continue that.
Oh, sure. So I think there, in terms of the studies out there, some nice publications coming out of Australia where they've looked specifically at women and then now men, and high impact loading exercises, even in those who've had things such as a vertebral fracture that personally made me nervous, but they have shown great improvements in bone density and safety. So it's that idea of gravity, and then so So even walking is great, but things, so I just think of kind of even jumping rope. You can go, the name of the trials were Lift More, LIFTMOOR, I think, and they go more specifically in the types of exercise they use, but any resistance, muscle training, muscle building, those kinds of activities are great. And then I can't help but say balance does tend to get worse as we get older. So it's never too early to start. There are many randomized controlled trials of Tai Chi in particular, where they've shown a demonstrated effect on decreasing the rate of falls. So those are kinds of the activities I would suggest. And then that last slide, if you go to the recording, you can look. Those are the latest guidelines for physical activity in adults.
To that end, Kathy, can you also touch on, you were osteoporosis. You had osteoporosis when you were younger, and you now have osteopenia. So what did you do to get to that transition to?
Yeah, thank you. Thanks for the questions. Yeah, I kind of skipped over that. Watching my video going, wait a minute, that's the most important part. So I was on Actonel for 3 years, and that was when I went to go get my PhD, and the doctor at Cleveland Clinic said, it would be wise if you got off these medications. So I think I had 3 years of a medication that is proven to work, and 3 years was sufficient enough for me. So that was in 2000, that was from 2000 to 2003 that I was on that medication. Then I went off and went back on oral contraceptives. During that time, I was in my doctoral program, and my schedule was very different. And for some reason, I had a lot more free time. I don't know how that happened, but I was very incredibly, I guess I didn't sleep. But anyways, I got very much into weightlifting. And I really think that that was the key. I'm also a swimmer, which is great for your muscles. But I think that combined with the medication, and the drugs do stay in your body for 10 years. They're kind of like this time release thing that tinkers down over time. But, so I clearly still had medication in my system. I think that combined with exercise, like serious resistance training. I wasn't fracturing at the time, so it was fine, although it was kind of this delicate dance. I didn't work with a personal trainer or anything, but I think that really helped. And so just, slow, steady improvement. And then when I did get that DEXA scan in 2014, which was or 2013, which was 10 years after I went off the drugs, I think just the cumulative effect of the medication still in my body, as well as the weight training. And I don't know if I was eating more. I've kind of weighed the same my entire life. So I fluctuate in those between 3 and 5 in the winter. I put on my little winter fat, and then it comes off in the summer. But I think that was the key. We will never know. We will never know, because there's no test that you can do that that determines that. But I think once I felt empowered and that I had time to actually exercise, and I have been able to keep up with that, but not nearly as much as I'd like to, especially during the pandemic with the gyms being closed and sitting all day. But just to give you some background. So if you know anything about DEXA scores, when I first was diagnosed, my hip was negative 2.5 standard deviations, and my spine was negative 2.1. And then I got all the way to negative 1.0 for my hip and negative 1.1 for my spine. So those were like very, very statistically significant improvements in my bone density. I've slipped back, ever since probably my mid 40s, and I am 53 now. And so we're just watching, and then I'm having conversations every year with my primary care about thinking about possibly going back on medication. And I am open to that. I don't fear the medications now, because I understand them a lot more, and I understand the benefits. Hopefully that answered the question. Thank you.
Yeah. And so I know some stuff has come in, and it's been mentioned, you have the bones of this old and bones of that. What's the difference between bone age and chronological age, and how does that correlate with bone mass?
Well, given that kids and adolescents, experience bone age, it doesn't. It's a good question. So Bone age is an assessment of the developmental stage of a bone based on the essentially looking at the growth plates because they ossify at a different rate. And age is an important factor in adolescents and young adults in sort of assessing the bone mineral density and how it compares with their peers. Just as height would on a growth chart, you have to be comparing to like peers. If there's a discrepancy between the chronologic age and the bone age, which there are various conditions which can cause that, you would tend to use the bone age as a better indicator of the sort of age of the bones when you're assessing the bone density. These are small numbers of kids that it doesn't end up being a huge factor in, and they're generally not looked at the same time. This is fairly high, esoteric, high end, but generally bone age tends to be felt to be a more an indicator of sort of more true biologic age. And for kids who have chronic diseases, it might delay their development.
And we touched on a bit of the stigma associated with it, and you hear about this fear of fragility. What can physicians do or other women do to help reduce this burden of stigma for women that are living with osteoporosis, osteopenia, and these challenges of bone disease?
I'm sorry, Irene, can you repeat that? Because I'm also trying to respond to chat.
No worries. I said, it came up about, there's certain stigma associated with osteoporosis and various stereotypes. And so what can physicians do or other women in the community do to help reduce this burden of the stigma for women who have osteoporosis or other bone diseases?
Well, I think that Catherine was correct in really talking about medical education for the provider. I think the providers themselves have a hard time assessing risk based on the DEXA BMD. So I can't tell you how many referrals I get for people who are were doing whatever they were doing, yoga, headstands and such. And then all of a sudden their doctor's like, don't do that. You could break in half. You have a skeleton of a 90-year-old, which I think is very unfortunate because that's not necessarily true. And then I think the other thing is not to think of the DEXA as the be all and end all. I mean, if you're fracturing, then that's something to take serious consideration, and you should see a specialist for that. If you're not fracturing, it's a good test, but it's not a perfect test. I get patients who are fracturing all over the place and their T-score is -1.2. And then I get people who have T-scores of -4 of their spine, and they have never had a fracture in their lives, and they're 78 years old. So I'm just saying that for people to understand that it is a good screening test. It's not a perfect screening test. And really, it is something to discuss with your healthcare provider. And hopefully, if the healthcare provider comes out that way, maybe one can gently provide some education by referring them to the websites that it's not the be all and end all. It's about preventing fracture.
And I'm seeing a couple questions that came in about treatment. And I know there's some stratified risk and things that that we talked about in the working group, but how soon should someone, does it mean if you are diagnosed with osteoporosis, should you immediately be expecting to be on medication and a therapy, or is there still kind of a watch and wait? Is there kind of a certain line or a point to which someone should say, I should be expecting to be on, a therapy, and maybe no recommendation per se on bisphosphonates and anabolics and all of that. But what is the expectation if you come in that osteopenia range or the osteoporosis range?
So I would take it as a way to kind of review and think about your lifestyle and such that way. Truly, most people worry about the hip fracture. The mean age of someone having a hip fracture is around 81. So if you're, 62 and find out you have low bone density or even osteoporosis, and thinking that medications for osteoporosis should maybe span, maybe 10 years at most, thinking about that in context and with your provider as to being targeted in terms of therapy. Again, really focusing on fall prevention, healthy eating habits, working on muscle strengthening. These are the things. I mean, I can't tell you how many patients, when they do make those changes in lifestyle, that their bone density actually goes up, much to their own surprise, because they've been told all along, there's no way, it's downhill after you're 25. You reach big bone mass, but it's simply not what I've seen clinically. And so the idea is that lifestyle changes can have major effects. In fact, studies are starting to show that if one is able to make those lifestyle changes, you can have positive effects not only on your bone, but so many other things that might be important to you as well.
That's a great piece. And I see we have a couple minutes left. And so before we wrap up, I want to ask one last question. And, we often have patients and healthcare providers that tune in to our webinars like this, but we also have researchers and policy professionals as well. What is one takeaway that each of you would recommend to our viewers to help them support improving bone health for women? And since you just kind of gave a little bit of a summary, we'll start with you, Dr. Cotto, to see if you wanted to tack on to anything, and then Dr. Sharp, and then we'll end with Dr. Loud.
Okay, I think my take home is that I didn't get to spend a lot of time about diet, but it's something that I counsel everybody about, regardless of what your eating habits are. I don't come in with any preconceived notions, but the idea is a well-balanced diet, fresh fruits and vegetables, minimally processed food. In a nutshell, the National Academy of Medicine has a website that shows you what a portion looks like. They've gone away from the food pyramid. And then finally, I think there were some questions about supplements and such. None of these are FDA approved. In 1994, they took away regulation from the FDA. So anybody can put things that sound really nice with packaging on bottles. And every single trial with supplements, for the most part, have come up pretty short and showing benefits. So if you're asking about K2 or magnesium, et cetera, strontium, I cannot say that all my patients 90 and above who are living independently have not made supplements their mainstay. It's usually my baby boomers, 60s to 70s, who somehow think that supplements are helping them live longer and more safely. And I'm just not seeing it clinically. And the studies also do not support it. So that's my ending statement, I think.
So just my statement as a patient, and someone who's in public health and whose specialty is in health communication, I would really like to impart, number one, to the patients out there who may be scared or have a million questions. Keep asking your questions, and sometimes you have to ask them to different people to get responses, because again, the science is still relatively new. So when to start medication, how much weight can I lift? These are also individual, and so there are a lot of trained physical therapists that actually have osteoporosis training, and they'll work with you in the gym. And a lot of people don't have money or time for that, but it's just something to consider. But also on my professional side as a health communication public health professional, it's really about the messaging and not using scare tactics, and making sure that your messages are tailored to different audiences, because we're not all white women with dowager's humps. And so, and prevention is key. So if there are healthcare providers or people in health communications on this, in this meeting, and I'm happy to provide suggestions on the side if people would like them, or hook you up with people that are experts in the field. And as patients, again, keep asking questions. If you don't communicate well with your doctor, if you can switch, I would say please do, because you have more power in this, just like Dr. Cotto said, with your diet and your exercise, and asking the questions that you have, and don't stop asking those questions until you get answers. Sometimes you're not going to like the answers, and that's okay, but make sure you keep asking. Don't be shuffled around and be despondent.
It's frustratingly simple and yet hard. As I said earlier, it's a, and the advice for bone health is the advice for general health for adolescents and young adults. It's exercise each and every day, healthy variety of diet, and maintaining a healthy weight for height and age. Dairy, I think, has value, and vitamin D has value in the adolescent growth spurt phase. Long term, probably, as Dr. Cotto said, not as important. And I would put in a similar plug, even though kids do fracture, you're not fragile. And just as we would probably never tell a patient with hypertension, which is merely a risk factor for a bad outcome, not to engage in life and exercise, we should never be telling patients with a measured low bone density to not be active and engage in life. I think those messages I've heard, I see it too in kids, and it just doesn't bear out. Low bone density on a DEXA does not predict fracture directly in an individual. So be active, be well.
Yes. And then really quickly, what type of healthcare provider, because it's an easy one, what type of healthcare provider is best equipped to handle bone issues such as osteopenia and osteoporosis? So you mentioned,
Yeah, so it depends, but generally in the United States, endocrinologists are the people who are most familiar with the medications and to be used in osteoporosis. But rheumatologists often deal with people who have bone issues because of the medicines they treat them with are associated with increased risk of bone complications. And then some primary care physicians, and there are only 7,000 geriatricians in the country, so they're not many of us, but there are a few who specifically work on bone as well.
thank you so much. Thank you all. You've been such an amazing panel. We thank you for your time and your insight, and also to Amgen and UCB for their support of this public forum and SWHR's Bone Health Program. We will send out an email with a recording of today's webinar to all registrants, as well as the post recording on the event's website, the event's webpage for future viewing. So please be on the lookout for that and feel free to share with others. In the meantime, in the chat, there is a downloadable image. I know we got a couple questions about that last slide that Dr. Cotto shared. And so if you click that, you'll be able to get access to that more immediately. We're also looking forward to highlighting more areas of women's health during National Bone and Joint Action Week in October. And so on October 17th, SWHR will be hosting a fireside chat to discuss lupus, that disproportionately affects women 9-to-1 compared to men. Later that same day, we'll have a panel of women talk about addressing barriers to care for women living with psoriatic disease. And for more information about bone and other women's health topics, resources, and events, or to sign up for our newsletter, visit our website at www.swhr.org. We also invite you to connect with us on social media, including our new SWHR_official Instagram account, as we continue the conversation with #SWHR Talks Bone Health. Thank you for joining us.